I'd like to thank Professor James Garden for his generous introduction and also thank the President of the Royal College of Surgeons of England and the organisers of the ASGBI meeting for the honour of giving the 2015 Moynihan Lecture. This is greatly appreciated. So why transplant surgery? First, why should anyone actually want to do it? And second, why should a large conference hall full of surgical experts from such a wide range of specialties want to hear about it? Well, because it's technically demanding, it's scientifically innovative, it's culturally and ethically challenging, and it's therapeutically successful. And I hope to convince you of all those things over the next 30 minutes. It's also very professionally fulfilling. The concept of transplanting organs, body parts, between one individual and another has fascinated mankind almost since the beginning of time. Cosmos and Damien, the patron saints of physicians and surgeons, are here recorded in this medieval painting, replacing a diseased limb with a healthy limb from a recently deceased donor. History does not record the outcome. But the founding father, really, from the surgical perspective of modern transplant surgery, Alexis Carrel, who made very important contributions, of course, to vascular surgery, but also very fascinated by transplantation and carried out a number of experimental transplants. But it's his work in vascular surgery which created the basis for the skills that are required for all solid organ transplants. That's joining blood vessels together. And he received the Nobel Prize for his contributions in 1912. But the first surgeon to actually transplant a human kidney into a patient was a Ukrainian surgeon, Yurii Voronoy, who carried this out in 1933, transplanting a kidney into the thigh of a young woman who was dying from renal failure secondary to mercury poisoning. The patient died 2 days later. And the first successful transplant was carried out by Joseph Murray in Boston in 1954. The recipient was a young man who was fortunate enough to have an identical twin brother who donated a kidney. The patient survived and lived for another 8 years before succumbing to recurrence of his renal disease. The donor lived on to die in old age not so very long ago. And success came thereafter with the development of new enabling technologies, immunosuppression, techniques for organ preservation, tissue typing, cross-matching, development of surgical techniques in a variety of different areas, improved anesthesia and intensive care. And it was the 1960s, 70s, and 80s that were a very, very exciting time because that's when these supporting technologies enabled novel transplant operations to be done one after the other. And the UK was an early adopter. The first kidney transplant was carried out in 1960. The first liver and heart transplants carried out almost simultaneously in 1968. The first pancreas in 78, lung in 83, intestine in 90, and most recently the first hand transplant in the UK in 2011. And one of the facets of transplant surgery is the way it crosses surgical disciplines, surgical boundaries. So a large part, of course, of transplantation is abdominal surgery, kidney, liver, pancreas, intestine. But the cardiothoracic surgeons involved really at a very early stage with heart and lung transplantation, and the most recent discipline to come on board, as it were, the plastic and reconstructive surgeons in the current century. Transplantation requires operative skills across a multiple of surgical disciplines. All transplant surgeons need to have skills in vascular surgery, but other skills are required depending upon the nature of the transplant: hepatobiliary, pancreatic, gastrointestinal, urological, cardiovascular, thoracic, and most recently, plastic and microvascular. And of course, one of the fascinations in transplantation is that it doesn't just stop with a surgical technique. Transplant surgeons need to be familiar with other areas of complex medical science. They need to understand some immunology. They need to understand immunosuppression and tissue typing. They need to be familiar with the management of complex, sick patients with multiple medical problems: cardiovascular disease, diabetes, renal failure, intestinal failure, liver failure, infectious diseases, drug toxicities. This is an area in which multidisciplinary patient management has been very well developed and, generally speaking, works very well. But there are three pillars which support and have always supported transplantation. The first is the technical, if you like, the surgical aspects of how you actually remove a diseased organ and replace it with a donor organ in such a way that it's likely to work. The second is the immunology, how we keep it there, how we control the immune response without killing the patient. And the third is the complexity of organ donation, the logistics, the legality, the ethical aspects, and everything else surrounding where the organs come from, donation. Transplantation has never been far away from the cultural and ethical controversy. Not many surgeons in their lifetime get their face on the front of Time magazine. This was Christian Barnard shortly after conducting the world's first heart transplant. For a short time, it is said that he was the most recognized human being on the planet. It was a hugely widely publicized and extremely controversial event. And more recently, very much in our own living memory, as it were, remember all the furor there was around the world's first face transplant. Lots and lots of debate, lots and lots of criticism of the surgical team that carried this out. And the fact is that transplant surgery, when it innovates, it tends to do something radical. It tends to do something which catches the attention of the broader public, of the media, the shock of the new. The fact that it's not been done before does not necessarily mean it should not be done now. And transplant surgery has, by its very nature, challenged and often changed cultural, legal, and ethical assumptions. Remember, well, perhaps many of us don't remember, but some will remember all the arguments about the concept, the legality, the ethics, the science around the concept of brain death. Heart transplantation, hugely controversial. Kidney transplantation, Joe Murray, at the time he carried out the first kidney transplant, was accused of being highly unethical by a number of people. Face transplantation, likewise. Xenotransplantation, organs from animals. We've not yet really got to that in a clinical setting, but it's already controversial. And finally, living donation. There are lots of controversies there. So, alternatively, the fact that it can be done does not necessarily mean it should be done. But the lessons we have learned are important when we make radical innovations. The first thing is it's very important the background research is done properly. The first clinical trials are meticulous. We don't want unforced errors. And the first clinical trials really need to deliver the proof of principle. We don't want, if possible, failed experiments because they weren't properly designed. And the need to follow fairly shortly after this with demonstration of patient benefit. Because what's really clear from our own experience is that once patient benefit is demonstrated, then ethical and cultural views will adapt, and often quite quickly, but nearly always with time. How much ethical debate is there now about, for example, heart transplantation? So I'm now going to talk about solid organ transplantation in the UK. This is a low volume by its very nature and high unit cost activity. The cheapest, if you like, transplant which we carry out routinely is a kidney transplant, which is of the order of £17,000 to £20,000. The most expensive is an intestine, for which the NHS tariff price is approximately £200,000. This is not cheap surgery. And you can see here that we're carrying out between 4,000 and 5,000 transplants a year, of which about 3/5 are kidney transplants, about 1/5 are liver transplants, and the rest are roughly evenly divided between pancreas, heart, and lung, with a small number of intestinal transplants. And this shows the success of transplant surgery. If you have a kidney, liver, pancreas, or heart transplant, the odds are very much stacked in your favor that you will be alive with a functioning graft 5 years on and thereafter. The results for intestine and lung are not as yet quite as good, but they are improving. And of course, transplantation requires organ donation. Donor organs come from deceased donors, and they come from living donors. Deceased donor organs are broadly categorized into two. The first are patients who have suffered irreversible loss of cerebral function and who've been declared dead by neurological criteria as a result of direct injury to the brain. These are known as donation after brain death, or DBD. And the second important group and expanding group are patients who are declared dead by cardiovascular criteria following a prolonged period of circulatory arrest. And these donors are known as donation after circulatory death, or DCD. And the important distinction is that a DCD donor, by its very nature, implies a period of hypoxic injury to the organs before they are retrieved. And it's DCD donation which is increasing most markedly in the recent decade. There's been a steady and impressive increase in the number of DCD donors. There's also been an impressive increase in the number of living donors, shown in the grey bars, although that increase seems to have levelled off, almost entirely in kidney transplantation, and a smaller but nonetheless welcome increase in neurologically dead DBD donors. So looking first at kidney transplantation. Kidney transplantation is a successful therapy and it's the treatment of choice for chronic renal failure for most patients if they're fit enough for an operation. And you can see here that the results of living donor kidney transplantation are superior to the results of deceased donor transplantation, but nonetheless, the half-life of a kidney coming from a deceased donor transplant in this country is about 13 years. At 13 years, there's a 50% chance that the kidney will still be functioning and that the patient will still be alive. If it was a living donor, that number becomes 20 years. So the long-term results are certainly successful. And it's not a lifestyle choice. It's not just it's nice not to be on dialysis. Approximately, kidney transplantation doubles the life expectancy compared to remaining on dialysis. It's a much, much better therapy for patients who are fit enough to have it. And kidney transplantation is cost-effective. Renal failure is a very, very expensive service. It's estimated to cost approximately 3% of the NHS budget. Dialysis, variably around the country, but typically costs about £30,000 per year per patient, and that's recurrent. A kidney transplant, £17,000 to £20,000, a one-off cost, and then a maintenance cost, which is predominantly drugs, of about £5,000 per year. So if you assume that the kidney is going to survive 10 years, which is conservative, each kidney transplant will save about £24,000 per year. That's worthwhile. Liver transplantation is also a success story. That's increased in the UK in the last 10 years. Liver transplantation has increased numerically by about 50%. There are more donors, there are more transplants, but the waiting list is increasing. That's more or less doubled over the 10-year period. And with the waiting list increasing, so is the proportion of patients that die on that waiting list. The results, the long-term results of patients who undergo transplantation are excellent, but it's fair to say that the new sources of donor organs that have been tried, have been exploited, have not yet resolved the donor shortage. So the use of living donation, splitting deceased donor livers into two to treat two patients, extending the criteria for donation, and particularly using DCD donors have not yet resolved the crisis in organ donation. And you can see the liver transplant donation here, and the green columns show DCD liver transplants, and the trajectory is much, much flatter than the one I showed you a few slides ago, which more or less reflects the kidney DCD activity, and very, very little impact from living donor liver transplantation in the UK. And that's typical of the West, although there are parts of the world where living donor liver transplantation is the norm rather than the exception, particularly India and the Far East. And the big concern of DCD liver transplantation is that it simply doesn't work as well as DBD liver transplantation. The period of hypoxia prior to retrieving the organ is particularly damaging to the biliary tree, and this cholangiogram shows ischemic cholangiopathy, which is a direct consequence of the ischemic period. This is a liver transplant recipient who's going to need another transplant if they are to survive. And it's fair to say that success in this area has been achieved only by a very selective approach to the use of organs. And there is no doubt that DCD transplantation is less good for the patients. Look at these odds ratios, 11 times greater risk of ischemic cholangiopathy, a 2.6 times increased risk of retransplant, and a 3.6 times greater risk that the organ will not function at all and need to be replaced urgently. So now pancreas transplantation in the UK. This is one of the league tables where the UK is very near the top, which may or may not be a good thing. We are second only to Norway in the number of pancreas transplants we carry out per million of population. And the operation which is carried out most frequently is the simultaneous pancreas and kidney transplant, in which the whole pancreas is transplanted with a segment of duodenum and anastomosed to the proximal jejunum, and the kidney is transplanted over on the other side of the pelvis using the iliac vessels, and the kidney, of course, drained conventionally into the bladder. And similarly to kidney transplantation, a pancreas transplant is not just a lifestyle operation. It has real effects on patients' life expectancy and on their complications. No one's done a randomized controlled trial comparing kidney transplant alone versus kidney plus pancreas transplant for patients with diabetic renal failure, and no one is likely to do one. But if we look at registry data, and these are North American registry data, the life expectancy of patients following combined simultaneous pancreas and kidney transplantation is roughly double that of diabetic renal failure patients who have a cadaveric kidney transplant alone. And there is exciting data emerging now looking at what happens when a pancreas is transplanted successfully in terms of the complications of diabetes. And it's beginning to appear that the microvascular connotations of diabetes can actually be reversed really surprisingly early, within a year of a successful pancreas transplant. These are exciting data, and we can expect to see more in the coming years. Transplantation of the intestine is more rarefied, still very low numbers, and it's fair to say that the indications are still emerging. But in general, these are all patients with irreversible intestinal failure. They're dependent on chronic long-term parenteral nutrition. They're suffering from failure or complications of medical therapy, particularly venous access problems and or progressive liver damage. They may have a non-resectable abdominal tumor, typically, for example, a desmoid tumor, and they may have intractable quality of life problems. And the nature of the operation depends upon the specifics of the individual patient. The simplest, the intestine alone, the intestine together with the liver, or what we call a multivisceral, which is the stomach, pancreas, intestine, with or without the liver. And the numbers are increasing slowly, but still small numbers, 26 cases done in this particular year. And the results are not as good as other areas of solid organ transplantation, but they are improving. Currently in the UK, 63% patient survival at 3 years for adults and 78% for children. And this brings us on to composite tissue transplantation. And I bring this in here because it fits with what we are doing in intestinal transplantation. This is a patient who underwent intestinal transplantation because of a very extensive desmoid tumor involving the abdominal wall. And so the abdominal wall was resected. And indeed, many patients requiring intestinal transplantation have suffered from many previous surgeries, abdominal sepsis, loss of abdominal domain, and there is really no space to implant an intestine. So being able to put a living abdominal wall in place is in many ways preferable to using biological measures and so on. And here you see this patient right at the end of the operation with a vascularized full-thickness abdominal wall transplant, vascularized using microsurgical techniques onto the inferior epigastric vessels. And here you see the same patient sometime later when the wounds are healed. So how do we organize transplantation nationally in the UK? I think it's fair to say that transplantation has historically been driven by enthusiasts rather than national planners, and that is a good thing. But it's also true to say that national coordination, quality control, and central commissioning are also now a good thing. And the command centre is NHSBT in Bristol. This regulates and coordinates. It runs the National Transplant Database. It manages the waiting list, the allocation algorithms, the transport of organs and teams. It monitors our activity and our quality control performance. It employs all the donor coordinators centrally, and it funds and manages the organ retrieval teams. And quality control is very important in surgery. National audit is essential. We've been doing it in transplantation for a long time. So all the providers are required in the terms of their contract to submit data to NHSBT, and we are compared and outliers are identified. This demonstrates the annual comparison of the pancreas transplant units, and as you can see, everyone is above the red line, which means there is no significant difference in outcome between the units, and there is no cause for concern. Individual units are monitored using the CUSUM system, and this is a very sensitive way of picking up when there's a run of inferior results, which the unit may need to be aware of and may take action over. Organ allocation, another central function of NHSBT, very complex. Allocation is essential, of course, in the management of any scarce resource, such as donor organs. And the algorithms we use to allocate organs to patients around the country depend on multiple factors. different in different organ types, but in general, there are two objectives. One is maximum fairness, and the other is best outcome. And of course, the two do not align. And what we aim to do is to get a reasonable balance between the two. So what are the challenges in 2015? I've selected two important ones: donor organ shortage and long-term graft failure. The organ shortage is all about supply and demand. The indications for transplantation have expanded. There are fewer patients excluded by reason of age or comorbidities. There is increasing incidence of liver disease, renal failure, diabetes, etc. There is, thankfully, a reducing number of what we call ideal donor organs. Those are young patients with head injuries without comorbidities. And as a result, the waiting list for all organs has increased. It is often said that transplantation is a victim of its own success. That in transplant circles is a cliche, but remember that a cliche is simply a truth that we've all grown tired of hearing. So what can we do about the donor shortage? We can find more conventional donor organs. We can utilize more of the organs we already have. We can protect those we transplant so they last longer. And finally, and I'm not going to talk about this, we can look for completely new sources of transplantable organs. So can we change medical and cultural attitudes to increase organ donation? A lot of effort's gone into this over the last 10 years or so, and there was a major initiative from the Department of Health culminating in a report from an organ donation task force in 2008, which made a raft of recommendations regarding training infrastructure, education, and recognition, with what we thought then was an extremely optimistic target of increasing donation by 50% within 5 years. But as it happens, that's precisely what has turned out, 50% increase in 5 years, and it appears to be a sustainable increase. Organ donation has grown substantially. And we're beginning to see the benefits. It may be a little bit too early to be complacent about this, but there is evidence that the waiting list for kidney transplantation is actually falling. There used to be more than 7,000 patients on the waiting list. There are now fewer than 6,000. The job is not yet done, but the movement is gently in the right direction. We can increase living donation, but there are real caveats with living donation. There are risks to the donor. Small risks in the case of kidney, bigger risks in the case of the liver, but they're not trivial. There are ethical concerns about coercion, about financial incentives, about exploitation of vulnerable donors. There are the logistic issues. But most importantly, of course, living donation requires a willing donor, and most patients do not have one. We can utilize higher risk donor organs. Well, of course, that's precisely what we are already doing. If we look at kidney donation in the UK, we can define what we mean by higher risk in terms of a number of fairly well-researched parameters. We are now transplanting 41% of our kidneys from high donor risk categories. That's more than twice what it was 10 years ago. And in liver transplantation, 48% of transplanted organs are now defined as high risk. What about organ reconditioning? What about doing something to a poor quality organ to make it into a safer transplant, to repair damaged organs and to quality assure them? Damage occurs to a transplant, to an organ, all the way through the process. Damage occurs before it's even left the donor, with brain death, with warm ischemia, with hypoperfusion, during cold preservation, by cooling, which is damaging, by cold ischemia, by energy depletion, loss of ATP, during the process of implantation with rewarming, and then when blood is provided to the organ with oxygen, it triggers the cascade of ischemia reperfusion damage, which causes a lot of injury. And then finally, once it's transplanted, the organ is subjected to immune attack, to toxic drugs, and to opportunistic infections. It's surprising that any of these organs actually survive at all. But the good news is there are things we can do at every stage. We can start to intervene in terms of the effects of brain death. We can optimize tissue perfusion. We can deliver oxygen. We can avoid cooling. We can support metabolism during preservation. We can block ischemia reperfusion. And we can look at new approaches to immunosuppression so the drugs are less toxic and the immune response is better controlled. There are all sorts of innovative areas which we will see in coming years. Reducing long-term graft attrition is extremely important because we've got very, very good at making grafts work for at least 12 months. And what we see here is a graph which shows kidney transplant survival in the UK in 3 eras, the 80s, the 90s, and the first decade of this century. And what's depressing about this slide is that these three lines are parallel. In other words, all the benefit has happened in the first part, in the first 12 months, and there's very little difference now in the rate of attrition compared to the way it was in previous eras. And the problem is that most transplant failures now happen late, so that's where we need to focus a lot of attention. So what about long-term transplant maintenance? What do we have now? We have immunosuppression, which is good at controlling early rejection. Not many transplants are lost because they're rejected in the first 6 months. But it's toxic and it's non-specific. It causes cancer, it causes cardiovascular disease. And it's not very good at dealing with the chronic immune damage, which we think is partly responsible for the late loss of transplants. And we have almost no effective way of measuring how active the immune response is. We have surrogate markers which are very, very approximate and not really terribly helpful. What we will have in the future, what we need to have, is immunosuppression, which provides effective control of the immune reaction to the graft, not just early on, but all the way through, which is specific and non-toxic. We need to modulate the immune response. We need to develop immunological tolerance, and there are already clinical trials in progress now looking at regulatory T cells, which is a technology whereby the cells that regulate the immune response are taken out of the recipient, amplified and put back in to alter the balance so the immune system is more likely to protect than to attack the transplanted organ. And there are other approaches using bone marrow infusion from the donor which are also showing promise. And we will have and have to have systems of measuring the immune response so we know what the immune system is doing before it's damaged the organ. So in the future, what will we see? We will see, I believe, new indications for transplantation, and we will see earlier interventions before the effects of end-stage organ damage are so severe. We'll see more patients with liver cancer, more patients with diabetic complications, with intestinal failure, with respiratory failure. We'll see organ resuscitation with older donors, indeed possibly even donors that die outside hospitals with obviously very prolonged ischemic injury to the organs. We'll see immune tolerance and immune monitoring. We'll see individualized patient protocols. We will see grafts that survive the patient's normal lifespan. More indications, more transplants, and better outcomes. But at the end of the day, of course, however interesting the scientific challenges and however challenging the surgery, it's the patients that this is really all about. Transplantation produces really great results in predominantly young or middle-aged patients with life-threatening or life-destroying disease. And it's not always easy, and it doesn't always work. And it still seems to take place in the middle of the night much more often than we would like. But transplant surgery is a most rewarding area of surgical endeavor. Thank you very much for your attention.